Well, welcome. Tonight, we're going to go over an institution and it's been around in Milford since we used to call it the Little Red Hospital. It's kind of like the little train that could. The medical center now is world class and has gone through some major changes. Well, I'll say changes. And we got the people here who have engineered them. So why don't we start with an introduction?
Hi, Al. Ed Kelly, president at Milford Regional Medical Center, which is now part of UMass Memorial. I've been at Milford for almost 33 years.
Hi, I'm Pat McSweeney. I'm the president of MRPG, Milford Regional Physician Group. I've been in that position for 6 years, but I've been part of the Milford Regional System for 26 years.
Evening, I'm Peter Smolowitz. I'm Chief Medical Officer at Milford. I've been here just about 5 years now.
Has it been that long?
Yeah. I started just as we were exiting the first surge of COVID. Quite a time to start, I guess, huh?
It just seems it went by fast.
Yeah.
So the biggest question on everybody's mind is, what's going to change?
So we're 1 year into the corporate affiliation with UMass Memorial. It's hard to believe. Some days it seems like a lot longer. Some days it seems like yesterday. So 1 year down, and generally I would say not a lot has changed for our community in terms of patient care. I think that's the really good news. Behind the scenes in terms of the non-clinical areas, we are kind of working hard to get on the UMass system. So IT systems are a big part of joining a new system and standardizing with UMass. So again, for the most part, we feel that is not visible to patients. And in Milford Regional, both at the hospital and the physician group practice is the same.
Well, I think their areas are the ones that people worry the most about. But you've got the piece that you got to keep the ship afloat, billing and all the admin work that can
Yep.
have a major impact on keeping the hospital open.
Right. And it's sort of it's kind of double the work because we have to keep the existing system going that we're on, but we also have to plan and transition to the new system. So just to mention that a little bit, Al, a couple of big pictures. So the non-patient care electronic record, so the administrative work, human resources, payroll, billing, we've just transitioned to the UMass system called Workday, which is a pretty popular vendor, very, very highly thought of, and so that just happened July 1st. So that was a big transition for us. And then the next big transition will be next April 1st, where the hospital and the physician group will switch over to Epic, and we'll be on the same information system throughout our system, which in my 33 years, we've never been on locally here at Milford, never mind joining the UMass system. So Dr. McSweeney's group is already on Epic. It's just a different system. But for the hospital, it'll be a big change, and it'll be an improvement. It's one of those things, a little bit of pain to get the gain.
Can you live without electronic records in today's day and age?
No, no. The short answer is no. I don't think there is anyone practicing medicine that's not on some form of electronic record. And just to elaborate a little bit further on what Ed said, there are certainly pains and inefficiencies of the hospital and the physician group being on different electronic health records. And the transition will be work, and there will be a learning curve. But if we look forward a year or so, when our hospital and our physician group are on the same record, never mind us locally with the entire UMass system, patient care is going to be so much better, communication is going to be so much better, communication with patients is going to be so much better. It's going to be a new ball game, really. As Ed said, we've never had that before. We've struggled with communication back and forth between the inpatient and outpatient setting because of data transfer and needing to work on interfaces and all the downfalls of those things. So, once we get settled in and having kind of learned how to use the UMass version of Epic, it's going to be a new day, and things are going to work much smoother. And I think even patients are going to realize it in the way that their providers have all the data that they have from all the care they get, and it's going to be beneficial to them.
Well, I would think joining your group is a critical phase, because how could an individual MD office support an IT system?
Yeah, I don't think they can without some support from their hospital, honestly. So you're right. I mean, the amount of money UMass, the system is putting up to make this transition to Epic is staggering. Yeah, EMRs are
Well, I mean, it's
incredibly.
just like, I go to my cardiologist, and I walk into Dr. Shine's office, and they ask my meds, all this basic information. And then I go to talk about my diabetes in Mendon, and they instantly are already updated from what I did at Dr. Shine's office.
Well, those doctors right now are on the same electronic record on the physician side. But what's not connected is if you go into the emergency department, it's not one medication record. When we move to Epic, it'll be one record. So we've made improvements over the years, but we still have different systems of medication records for example, of what
So
you're on.
Jeff's operation in the ER is on its own?
It's on the hospital system of Meditech.
So how does he get information that my physicians know?
They're able to access, they have to manually go to different systems and check in. We have pharmacy techs that do that for us right now, where in the future we won't have to do that.
Well, that sounds interesting, because you kept talking about Epic and how much money it was going to be invested in bringing Epic up.
Yeah, Epic and Workday overall are about $50 million. So that's something that Milford couldn't do on our own.
Just for Milford?
Just for Milford, yeah. So I think, for me, having spent so long here as the independent Milford Regional, it was really terrific. But COVID changed that, the losses changed that. And once we realized that, I think once, when I talk to groups, once, I kind of go over our history, our financial history, and realized we couldn't stay as we were. Joining another system made sense. So then, okay, what are you going to get from that system? And so a big part of it is the investment from UMass, a commitment they made to us in terms of Workday and Epic. About $50 million is the investment locally for us, but also other investments in plant that we had to put on pause because of the losses. So they've made a commitment to us over 5 years in terms of our capital budget. So there are changes like that we said, okay, we have to join another system, but we're going to see a lot of investment in Milford because of that.
Was that the driving reason for joining UMass?
It was really the losses that made us realize that we couldn't stay independent anymore. You can lose money for a short period of time, and how you do that is you don't invest in your plant, you don't invest in capital. But once it's gone on for a few years, it's not sustainable. So you're spending down your cash, you're not investing in your plant. And so it was really the losses that said, hey, we don't want to change who Milford is. That's what we like. Patients like to get care locally. They like the physicians that we have, 5 urgent care centers that we have right now, great services at the hospital. So they like that local care, and we recognize that we either needed to change our structure or dramatically change who Milford Regional was. And so we didn't want to do that. We wanted to keep intact who Milford Regional was and is going to continue to be. And we felt the best way to do that was to join a bigger system. So I think you had asked the question to start, what's changed? And largely to the public, to the community, not a lot has changed, which is good news.
Yeah, the infrastructure, the back office, we don't feel as patients. But your part of the world, the interface with physicians, with medical decisions, and we're going to put you on the spot, Dr. Peter, about things like vaccines. That if it changes, you feel right away. The quality,
Yeah.
you feel right away.
Well, we're, in terms of our system, our medical staff, we want to continue to drive decision-making for patients. And so Dr. Smolowitz, in his role as CMO, is really the person that deals with our local medical staff, which is really critical. And again, they come from all different avenues of different systems, but also interfaces with UMass to have so we try to have a standard plan with them. So everything goes through him.
I will say one thing on the part about IT systems that impact physicians and patients that patients will notice at some point is UMass is heavily invested in the area of artificial intelligence, and one of the sort of rising areas within that I think is going to be really cool is what we call ambient scribing. So essentially what happens is a doctor can walk into a room with a patient, sit down, have a conversation with them, never look at the computer. They'll go back to the computer and that entire conversation will be recorded in a normal, organized way that talks about, like the history, the physical examination, the parts that they at least speak out loud, and then their medical decision making. I could say to you, Al, based on XYZ complaint, we're going to go ahead and get a CAT scan, and I'll follow up with you in a week on it, and that'll already be recorded in the medical decision making. So you can spend more time actually talking to the patient and less time sitting in front of the computer. So that's, I think, where the future is headed, and it'll be great for patients.
Well, that would be a wonderful step, because all the physicians I know of, the biggest complaint I heard was that they're spending too much time not dealing with the patient, but dealing with the paperwork afterwards.
Yeah, it could also do things like automating the prior authorizations. How doctors have to go through an insane amount of paperwork just to get approval to get a study or something. I think AI could be helpful with that. So you're right, it brings us back to the bedside more.
Yeah, for a while, it seemed like they had an intern or somebody being a scribe.
Yeah, MRPG has been using scribes for quite a period of time, and we started with another person in the exam room,
Right.
typing along as the visit went on. We progressed to asynchronous scribes, where we recorded the visit and then someone listened to it and recorded the note by listening to it, not in real time. And now we're using the AI as Peter mentioned, that are doing the notes for us. So we're already using the AI technology with a fair number of our providers in MRPG. And the AI still is not perfect. You can't just let the AI do it and then the note's done. There's still a fair amount of review needing to be done.
Yeah, but the
It's not
intern,
perfect,
the
but
scribe isn't perfect either.
no, right, true. So
But
it's getting there, but it's
we're able to
improving.
get this as part of a bigger system where we couldn't have got
Yeah.
that independently
Yeah,
before.
and
It needs
And
work, but it's got a good future. I
it
think.
does, and UMass is, I think, when you ask the question, what are the benefits of joining a system like UMass and UMass specifically, I think they're heavily invested in technology, AI being part of that technology, scribes being one of them, but also using AI to look at populations of patients and look at things that may be being missed by patients who aren't going to their doctors regularly, or their doctors are focusing on other things and missing things. So identifying opportunities for earlier treatment of diseases that are preventing complications over time. Those are things that UMass is looking at, populations of people through AI, which MRPG as its own didn't have the resources to use that kind of technology. So that's exciting.
Your ability to recruit, now that you're part of UMass, has it changed? I mean, if I remember right, there were 2 or 3 primary care physicians in the area who didn't work for you, but I think you had 97%.
Yeah, I still think in the greater Milford community, the majority of the, providers are in MRPG, or, there's still some of the Optum Reliant. I think the days of the independent physician or small independent group are going by the wayside. I think physician recruiting in general is extremely difficult. I think it's still kind of too early to say whether it's easier or more difficult being part of the UMass system. I think it's still extremely difficult. We had a really good stretch. We just
And
had.
how did you hire 3 new ones?
I think we got lucky. I think we got a couple of people who were
It's his personality.
looking. Yeah, it's my
I
charm.
think, Pat, I think Dr. McSweeney's being very modest here. Physician recruitment nationally in our state, and particularly in our state, is incredibly hard. So I, just being together with my family recently, 3 individuals lost their PCP in other parts of the state. It's really, really challenging. And so we're not perfect, but I think, physicians are looking to be employed today, and they're looking for a good place to practice medicine. And again, I think it's a compliment to Dr. McSweeney and the team that, when you have a good system, it's easy to bring in new physicians. So I think, relatively speaking, we're doing okay. We're knocking on wood, that relative to other community systems. Now, patients are still frustrated because, it's harder and harder to get tests scheduled to see physicians. And as Dr. McSweeney mentioned, physicians aren't getting any younger either, so that's something we're challenging with. But I think, I think we've been progressive, and you've been progressive in terms of advanced practitioners, which have also helped a lot. So it's a good place to work and practice medicine.
But Dr. Pat, is the supply keeping up with the demand? I
No.
mean, we have the same number of med schools. They're graduating the same number of physicians.
Well, if we're talking about primary care specifically, I think there's definitely been a problem for probably at least a decade, if not 2, fewer and fewer going into primary care. And that's certainly, it's financial. Primary care physicians get paid less than the vast majority of the other specialties. Medical debt is huge. I don't know what the numbers are, but, students coming out of medical school are probably owing somewhere between $250,000 and $500,000 in debt, student debt. And you can't take a job with a salary, you can't go into a career with a salary of $200,000 to $250,000 and pay back $250,000 to $500,000. You have to you look at a job that's going to pay you $500,000 a year or more. So they go to medical specialties, surgical specialties, which pay much more. That's why there's been a shortage of primary care physicians for a long time, and that's why 1 in 3 Massachusetts primary care physicians is over age 60. That's a scary statistic.
That's a scary movie.
That's a scary movie. Yeah, that's a scary movie for me when knowing that I'm going to have to replace a third of my primary care docs in all likelihood over the next, if they average retirement age is 65 in the next 5 years. Yeah. And so, what Ed alluded to is that, more and more of the primary care is going to be provided by nurse practitioners and physician
I was going to
assistants.
say, it seems like I'm seeing more and
Yeah.
more nurse
Yeah.
practitioners
Yeah.
than my
Yeah.
primary
And
care.
and we've got some excellent ones who are very, very good. And I've sent family members and very good friends to NPs and PAs to be their primary care providers in our group. So I think it's all about the individual. I think 2 years ago I said in 10 years the majority of primary care will be provided by NPs and PAs. I now say in 5 years the majority of primary care will be provided by NPs and PAs. That's just the reality of it. Unless something fundamentally changes in the way primary care physicians are paid compared to other specialties, it's not going to get better.
Well,
There's been talk about that for years
Right,
and
and
years,
it's-
and years,
right,
but no action.
right.
Yeah.
Right.
It's interesting because up at my old school, Holy Cross, they do a lot with medical schools. So you get the kids coming into choices of what they want to be when they grow up. And it used to be that, well, I want to be a physician because I'm guaranteed financial independence. It's all, and you sit there and say, don't do it. Unless I hear a passion for medicine.
Yeah.
It makes no sense to me because, and I'll get in trouble with you guys for saying it, but physicians work too hard and get paid too little compared to business people.
I'm not going to argue with you, Al.
And I mean, the responsibility, when you think about putting your child in the care of a physician, I can't think of anything more critical. But, you know, it's, like I say, I tell them, if you have a passion for medicine, great career.
Yep.
But as a primary care, I mean, first of all, you're getting out of school when you're about to retire. You know, by the time you put the subspecialty and the specialty and all this stuff in there, they're 30 years old before they can earn $1. And then the
At least,
debt,
yeah.
at least.
Yeah.
And then the debt they're holding, it's bad enough the kid's walking out of a BS owing $100,000. And now it's $100,000 a year for
Right.
school. I don't know what med schools are.
Probably around that.
Yeah.
Yeah. It's a challenge.
Yeah.
In summary, it's a challenge.
I mean, it is. I reflect back. You know, it's been a wonderful career, but it's been a commitment. It's not. You know, it's not easy. Going through med school, residency, sleepless hours.
Don't get me wrong.
I think a lot of docs though nowadays would say, like, if you could just take away all my paperwork, let me be at the bedside and be a doctor. I'd
I
be
was
okay
gonna say,
with
don't
that.
get me wrong, I still think the world of these physicians. And doing away with more of their admin has got to make their job more fulfilling. But
Yeah, they got to
still,
find a way to bring back the joy in medicine to them. It's a lot of.
well, yeah, when I was a kid, Dr. Capisi, Dr. Mastriani, I mean, there were 4 docs in Milford, and they knew you. And if you didn't do what you promised to do 6 months ago when they saw you, somehow they remembered. There was no electronic records, but they remembered, and they would just look at you and. Today, I mean, when I think of I got 15 minutes with my primary care, how much can you really expect to get out of that? What's a CMO?
What is a CMO? You mean a chief medical officer? Or
Yes,
is there a
we
different one?
threw out the title CMO, and a lot of people.
Yeah, I get often asked like to define what it is I do, and as I've thought about it, I have really 2 major responsibilities. Put it pretty simply. One is to safeguard the health and safety and quality of care for the community of patients, and the other is to safeguard the well-being and the joy in medicine of the physicians and the clinicians that work in the hospital and the organization. It's really what it is. There's a lot that it's encompassed within that, but it's honestly just taking care of patients and taking care of the clinicians that work in our organization.
But
the best we
today's
can do that.
media,
Yeah,
I mean, Dr. Pat brought up that you can get a study to show almost anything depending on how you design it. People don't trust.
yeah.
You know, you get the CDC experts, the FDA experts, and the head of the FDA, which always amazed me, is not a physician. You guys are the ones we trust,
Yeah,
you know.
I hope so.
Well, you've been here 5 years, and you've always been consistent. You guys have been here decades, and familiarity breeds respect. Because we haven't heard any scandals, any terrible things at the hospital, or the medical center, sorry. Still the Little Red Hospital to me. But things like to vaccinate or not to vaccinate, hot topic. What's your
To vac-
position?
The problem with that one is there's no debate on this one. It's a sealed and done debate. Vaccines save lives, and the idea that there's a controversy over vaccines it's insane to me, and really a political topic which I'll stay away from. But from the pure science, you know, it's sad to me that we're having a discussion about children dying from measles in a day where measles should have been completely eradicated. The idea that, and I think what I worry about and hopefully my message to this community for this winter is, get your flu vaccine and get your COVID vaccine. There should be no debate that those can both reduce contagiousness of disease and reduce people dying from especially the flu and also COVID and severity of disease. So we could have a winter where we're overburdened with people dying from the flu and COVID and ending up in the hospital by not getting their vaccines, or we could have people getting their vaccines and having a much more manageable winter. And that's people's choice, but they gotta look
But
at
now
the
I'll
evidence
admit
on
I'm
it.
ignorant, because I haven't found the tie, peer-reviewed journals, data that links autism to vaccines. And, you know, a lot of people get scared. It's my child's life.
Yeah.
If I vaccinate him or her, am I going to cause autism? But I haven't seen anything that tells me there's a definitive link.
Not just that, I would say there's clearly been studies that show there is no link between vaccines and autism, period. That debate is over and done with. But as you noted before, and what Pat was saying, is you can find a study to draw on in just about any journal randomly that shows something, and if you want to believe it, then you'll hold on to that.
And I think the thing with autism too is autism can be such a strain on families that not having an answer as to how did this happen or why did my child or children get this, that sometimes you just look for an answer, even if the answer isn't founded in science or anything else. Sometimes it's easier to accept an answer that isn't founded in science than not have an answer.
If I'm a political science major or a sociology major, do I really understand the science to begin with?
Right.
I think what you're saying is profound. I'm worried, did I do something
Right.
that negatively affected my child?
Right. And sometimes it's easier to just say, yeah, there's this might have done it, as opposed to saying, I don't know. Right. Or, geez, was it something else I did? But you know, the bigger issue is vaccines in general are very much safe, and they save way more lives than they harm. Are there individuals who have adverse effects from vaccines? Yes, but that's true of every medication.
every
That's true
medicine
of
in the
every
world.
single medication, every single surgery, everything we do in medicine. There is a potential for harm, but there's much greater potential for success. I mean, I can't believe that I'm old enough that a new vaccine in my medical career has eradicated disease. When I was a resident, the newborn nurseries were full of babies with meningitis. And now there's a vaccine for newborns for meningitis that they get at 2, 4, and 6 months old. And guess what? There's no more meningitis in newborn in NICUs in the United States. There's no more meningitis since I've been, and I don't think I'm that old, that a vaccine-associated disease has been eradicated in my professional career.
But we could say the same thing about things like measles. There's no measles.
Right, but that's a lot older than me.
I think it's hard for people to appreciate when something is absent or not there.
Right.
It's much easier to latch onto something when you see it in front of you, like autism. That's kind of what Pat was talking about in terms of the dynamic of thinking about that. But I think it's important for us to just say very clearly, vaccines save lives. And the one thing people can do to help, both with pediatric illness and for this winter is get vaccines.
Well, question, should I get my flu shot separate from my COVID, or does it matter if I get them
Doesn't
both at the
matter.
same time?
Doesn't matter. Getting them together or separate has been proven to be fine.
Because last year they harpooned one arm for COVID and one arm for flu.
Yeah.
I say get them together because you're more likely to get both if you get them at the same time.
Well, I mean,
I like separating them only because I don't like to get shots. So I'll get them, but I got to get them separated.
things like TB, that if you would ask me in a blind question, I would have said, not an issue, it's gone. But yet, we started getting people moving to Milford from areas of the world where tuberculosis was still prevalent. And we had to deal with it. I mean, we got criticized on the finance committee because we increased the visiting nurses budget to help enforce compliance because people weren't taking the pills. And it was funny because somebody asked me, why did you spend money on something like that? And I said, why do you think we did it? I'd love to say we did it for the goodness of our hearts and forget the fact that if a child comes in with TB to an elementary class, it's my grandkids, it's my neighbor's kids. They're all going to share in that wonderful disease.
Yeah, it's the same thing with the vaccines. Getting the vaccines helps reduce the spread, keeps your own child and others safe.
So now, what are the big vaccines we should make sure we get? COVID, flu?
That's it in terms of the winter respiratory season, but I'll let Pat talk about the primary care related stuff if there's anything new on the.
Oh, boy, you put me on the spot. I've been practicing
No.
6 years,
Hey,
so I'm
I
a
haven't
little
ever
rusty.
I
practiced
think it's more
primary care,
important to
so
go see their doctor.
Yeah, I would say
Go later,
discuss,
yeah.
yeah, good, thanks, Ed, for saving me. Yeah, talk to your doctor about it. Thank you.
Yeah.
You know, you had asked a question to start about what's a CMO do. You know, it reminds me that Milford, you know, we were a little hospital when I started here. We're much bigger, but we're still not huge, but we're pretty complex. You know, one of the things that makes Milford a strong community hospital with a lot of services is getting physicians to come to Milford, and that was the decision to start Pat's group and to employ physicians and to put them in the community, put them at the hospital. But in addition to that, we also get important physician services from 4 other academic medical centers, plus private docs. So, you know, UMass, Dana-Farber's here, Boston Children's is here, Brigham and Women's is here, and then private. And so coordinating all of that and really making all the, you know, physicians connect, work together as a team is what is partly what a CMO does. And so we're really lucky, you know, to have physicians. It's culture that like to work here, that seem to work, you know, really well together. So you might think that companies that, you know, might be competing, you know, that might be visible, and it's really not in the hospital. So we feel, it just reminds me of what a special place, you know, Milford has become in terms of services that we have here. And so again, back to your first question, we don't want that to change. That's really, and UMass has said, yeah, you're part of our corporate affiliation. We want to do more services here, but Milford is a special place because of these relationships that we have. So that's you know, part of Dr. Smolwitz's job in terms of making all those pieces work together.
Did we lose anything when we became part of UMass? Were there any corporate alliances? Because it seems unique to have 4 academic centers working with us.
No, we've made some changes in services as they come up for contracts that we've put them out to bid. So one service that changed, we had Brigham and Women's thoracic surgery. We've since changed that to UMass. But the medical staff helped to drive that. That was a contract that was up. And I forgot to mention, in addition to that, you know, we have a formal medical staff, Dr. Cromaldi, who, you know, is local and president of the medical staff. And so he's instrumental. So when we go to look at a service like that, we bring in the medical staff, we bring in the medical staff leadership. You know, Peter brings people in, and we really try to have a decision that's clinically driven as opposed to financially or politically driven.
Is there that much difference financially, whose thoracic services you use?
It can make a difference, yeah, it can. And then it's not just what do we pay for that service, but it's also, you know, what do they keep local? And so it's important to have a kind of a thorough vetting of people and what they're going to do. So I think in the end, we feel very good about the process, and we feel very good about the selection of UMass thoracic surgery.
Well, our alliance with Dana-Farber has seemed to be critical.
It has been, yeah, it has been
Is there
critical.
any changes with they're changing their alliances?
They are. So in Boston, it's a bigger deal where Mass General Brigham, particularly Brigham and Women's, is breaking their longstanding relationship with Dana-Farber. And Dana-Farber is aligning with Beth Israel, and Mass General Brigham is going to develop their own cancer medical oncology program. Some of it they already had at Mass General. So that's kind of a big change in Boston. But locally, we have separate arrangements with Dana-Farber and Brigham and Women's for radiation. And so we don't anticipate any changes. We haven't seen any changes. And again, sometimes it's not about the corporation, it's about the people. So we know the Dr. Constantine's, the Dr. Cadis's, you know, the Dr. Oreos and company in radiation. And so that's kind of who we know.
It's funny when you say Dr. Cadis. How many times I've mentioned, this wasn't Dr. Katis to my mother, it was Dr. Mona,
Oh,
you know,
Yep.
and it made such a difference when my mother was diagnosed with intestinal cancer, that it was local. There was a trust. Plus, you didn't have to drive all the way to Boston, and, I mean, you know 100 times more than I do the effect psychologically on patients. But driving down to Prospect Street in 10 minutes certainly didn't add to the agita that my mother went through. But then for years, every so many months, she went to see Dr. Mona, and she was always there. That's got to be unique. At least it feels unique, because you talk about, well, you guys are rookies. You've only been here 20 years. How do we compare to other medical institutions as far as staff retention?
I don't know if this answers your question directly, but I think one of the things that we've, community hospitals have undergone a lot of changes, and a lot of them have downsized services because either financially on their own they couldn't do it, or they've joined another system and they've still downsized services and and have transferred. So I think partly because of our geography, local services are really important. So we've done well with that compared to other community hospitals that have undergone changes, and that's something that we want to continue. So we want to take care of patients locally for what a community hospital should do, but knowing the threshold that a patient needs to go to an academic medical center. So we feel like we've retained that. I think in general, a lot of Milford Regional is our staff. It's culture at the hospital, culture at the physician groups. So retention has been, again, knock on wood, very good.
And I'm the newbie of the group, only having been here 5 years, but I think when I got here, and I still remain astonished at how long some of the, not just the physicians, but other staff and employees of the hospital have been here for decades. I mean, you'll see people that are here for 45, 50 years or so. So there's something about the culture of Milford that has been really amazing, really strong, and like a family for decades and decades. And so I think you're right to kind of reflect on that.
Well, we always seem to be pirates as far as stealing people out of UMass anyway. I mean, that relationship of having them do their rounds through Milford, I always thought was a backdoor way of recruiting new talent. Is it still working?
Yeah, I think we built a lot of our physician group in the, maybe the 2000s, late 90s, or maybe the ones that are kind of getting up in their 60s now. Certainly a huge portion of those were UMass people. I think it's been less so over the last 10, 15 years. Probably more of our specialties like hospitalists are coming, because the people who come through Milford are internal medicine residents, and the majority of those people go into medical specialties or become hospitalists, not primary care docs. So it's been a good source of hiring hospitalists, but not necessarily other areas where in the past I think a lot of our internists are UMass trained and rotated through Milford back then. But to go back to your earlier question about people coming here and staying, I agree. I don't have the statistics on it, but it's extremely rare for someone to leave MRPG and practice in Massachusetts. I like to say the people who leave MRPG are selling their house and moving somewhere else for family reasons or whatever. And we historically don't actively recruit in other health systems, meaning we don't cold call or send cards and
You
reach
don't
out
try
to
and poach.
Right, and we've hired from every surrounding health system in a 360-degree radius of Milford in the past 5 years. So we've had people join us from every health system.
Besides primary care, what is the next big area of MDs you need to recruit?
Help me with that, Peter. I mean, because a lot of what, when you think of the outpatient care, which is the majority of the work that MRPG providers do, you always think first primary care. A lot of the other care we do, we start by thinking about what are the hospital needs, what are the needs for the patients in the hospital, and then that's supplemented sort of with the outpatient care they provide. So, I think right now, a couple of the specialties that we really have issues or potentially access problems, ear, nose, and throat surgery, urology are a couple of the surgical specialties, endocrinology, diabetes care. Diabetes is so prevalent, and we could definitely use another diabetes specialist. So those are the ones that come top of mind right away. Peter, you think of any others?
Yeah, I
Ed?
think that's
pretty
right.
good.
Yeah.
We like to coordinate between sort of what the needs are in the hospital and the outpatient setting and make
Yeah.
sure we're working on that together.
So those would be the specialties that I can think of.
The urgent care clinics.
Yep.
They seem to be becoming more and more urgent.
Yeah, well, I think that's part of the challenge of, the way in today's day, everybody can get everything immediately, right? On their time, you can have food in your house in 20 minutes, you can have clothes, whatever you want, you can get it immediately. And, we haven't figured out how to do that in healthcare in general. And, but patients want, because they're used to that in the rest of their life, they want to get their problem addressed now when it's convenient for them.
Well, that's Ed's fault. He hasn't
Not-
put out the memo that says, on Mondays, you can have these sicknesses, on Tuesdays.
So I think some of it is in response to kind of the way patients are as customers now, is that, they want to do it when it's convenient for them, and we haven't quite figured out in healthcare how to be so customer or patient friendly, customer friendly to have our chronic care model matched with our urgent care model so that we can see patients on their time. And I think it's also confounded by, it's hard to take care of a bunch of patients with chronic disease and also at the same time take care of patients with acute needs and balance that in the same day. So a primary care provider to try to take care of all their patients with chronic disease and then yet still be available for other patients with acute needs when they want to be seen, when it's convenient for them. It's hard to do all of that and be one person. So I think that's where the urgent cares have really been important. And also to make sure that patients are not using the emergency department for urgent care, so that the emergency department can really be for patients who need advanced care, advanced imaging, not people who could be seen in urgent
Well, the
care.
insurance companies are certainly helping you with that.
Yeah.
To go visit Jeff Hopkins' ER is $500 deductible on a lot of plans.
Yep.
So a mile distance of driving,
Yeah.
and you're faced with $25 or $50 copay versus
Right.
$500.
Or less for our Milford urgent care is probably even quarter of a mile, right?
Yeah.
Yeah.
I think our urgent care centers, particularly the Milford regional ones, have been really critical to our success. It wasn't that long ago. I mean, we haven't had a lot, but we've had a couple of peak points, largely before Dr. McSweeney took over, where we just didn't have enough primary care physicians. We didn't have the advanced practitioners that we have today. So if you called your doctor's office and he couldn't see you, what'd you do? You went to the emergency department. So we had sort of more routine business going to the ED, which wasn't good for the hospital, was expensive for patients. And so setting up urgent care centers really helps stabilize the physician primary care offices. So they can book better in the office because they don't have to worry about how many people am I going to have calling today with sick calls. It was really instrumental during COVID in terms of taking care of the COVID
Well,
population.
I think you've gotten over a couple things that when you first talked about urgent care, first question came out is, am I going to go see the JVs? And then when you came out and said it's the same staff, whether you go to Milford emergency room or the urgent care, that certainly
Yeah.
made me feel a lot more comfortable.
It's the same IT system of MRPG. I just think, um, sometimes you can get a little sentimental here, but I think what makes Milford Regional special is we just always try to do the right thing. Sometimes there's financial constraints, but, just good physician services, and supplementing them with, the advanced practitioners have been part of that. Urgent care, good emergency services, good, community hospital services. That's kind of just what we've been trying, to do right along. And so part of that is the urgent care centers became the right thing to do to serve the community.
Well, the other thing, besides having confidence I'm getting the same level of care, was the wait. I go into the ER, and they're going to take care of the people who are in dire need. My kid hurt an ankle. I'm just scared to death that it's more than an ankle, so I go to the ER. And I may have to wait. Now, in the urgent care in Milford, I've had to wait 10, 15 minutes.
Yeah.
But compared to an ER, I'm
We-
joking, there's 10 to 15 minutes of nothing.
We do a really good job in our ED in terms of wait times, but we can't sugarcoat. I mean, you can have a weekend where you've just got 80 patients in the emergency department, and you know what? That's not going to move quickly, particularly if some of those patients are really, really sick. And so, we've gotten feedback about that, and we do the best that we can. And, it could be dramatically different the next 2 weekends. So it's hard to manage, and our staff does the best that they can. We've got great nurses at the hospital, great team in the emergency department that have been there a while, Dr. Hopkins and his entire team. We do the best we can, but sometimes volume can just overwhelm us.
But I just think by nature, you get car accidents, you get things that are going in there that demand a lot more attention than me sniffling. And I'm
Yeah.
in the same room.
I think it's just hard when people, you're totally right. I think the challenge is like when people show up into the emergency department and they feel really bad or are sick, it's hard to wait. And so even 2-hour wait can seem like, forever. But I mean, to Ed's point, like it's unpredictable what each day in an emergency room is going to look like. The number of people, the types of acuity, how sick people are. So I agree, the staff does an incredible job, but there are going to be some days where people get more frustrated because they have to wait longer, and we hate to make people wait,
Well,
but
the
that's the
tension
reality.
level's up anyway.
Yeah, exactly.
You
Yeah, when you're feeling bad, you don't want to wait.
And we are interdependent on the rest of the healthcare system, so that if we have patients in the hospital that are ready to be discharged, so sometimes they want to go to skilled nursing facilities. If they're busy, if they don't have enough staff, it clogs our inpatient areas, which backs up our ED. So then sometimes the academic medical centers are full. So we've got someone we want to transfer that needs a higher level of care. We can't do that. That ties up resources. So it's
Yeah, but
It's-
Jeff Hopkins gets blamed.
it's complex.
The
Yeah.
Milford
I don't mind
system-
when he gets blamed, because sometimes I get blamed.
But you think about it, you're holding on to my mother. Why aren't you releasing her?
Yeah.
Well, Countryside isn't ready to take her, or another place isn't
Yeah.
ready to take her. I don't want to hear about them. You have my mother.
Yeah.
Now, speaking of that, the trend seems to be more or less days in the hospital. When my mother had her knees done, she had a week and a half, almost 2 weeks of rehab. Am I right in hearing that it's going to almost outpatient or 1 day?
Yes, yeah, it's technology, it's also, I think, learning what's better for patients, so being, I think some of the more historicals is less active, and again, I think younger patients are experiencing, these like joint replacements, and so therefore, they're more active and they're ready to transition out quicker, so.
But Peter, Dr. Peter, how much say do you have? I mean, if you turn around and say you should have 3 days or 4 days recouping in the hospital, isn't that dictated by insurance?
Some of it can be, but I think the simple way I look at it is that we try to do what's best for each individual patient. So, and there are studies that show that like patients patients want to be home as opposed to
yeah.
in the hospital if they can be. Obviously, you want to be in the hospital if you're really sick and you need it. But if you don't need to be, patients would much rather be at home. So whether you're, 65 and getting a knee replacement and can go home and be in your own bed and be more comfortable, or, more and more now the hospital at home was cut off by the government shutdown, but before that, there were growing programs about keeping patients at home who needed hospital level of care because patients are much happier and more comfortable in their own environment. So some of that is dictated by that, but the reality is we want to get patients out of the hospital as quickly as we can, as safely as we can when appropriate.
Well, the safety seems to be critical because
Yeah.
when my mother, and I use her as an example, was discharged, I'm there, my darling bride's there, my ungrateful offspring are there. There's a network there to support her.
Yeah.
Not
But-
everyone has that.
But as I
Yeah.
say, what happens to the poor senior who lives on her own or lives on his own?
Yeah, it becomes a challenge.
It's
If
a
they can go
challenge,
home
yeah.
safely at some point, they do. Otherwise, they might need a short stay at acute rehab facility or something. But especially for the elderly, we try to make sure the elderly stay in the hospital as short as possible because there's definitely data to say that each individual day that an older patient stays in the hospital is a higher risk of fall, of confusion and cognitive decline, of weight loss, of prolonged stays in nursing homes. So we want to do the right thing by getting patients out in a timely manner. But they do need their family support, and we ask
Yeah, I
for
don't
that.
know
And then
how-
Al, unfortunately, there's a lot of cases where you list those people like you and your lovely bride and your ungrateful,
My darling bride.
your darling bride and your ungrateful offspring. Well, there's plenty, and it sounds like all four of you are able and willing to assist your elderly mother who needs some help at home. Too many cases, there are those same people at home who are unwilling to help and are expecting the patient to stay in the hospital when there's no medical indication because they're unwilling to help. And
You know,
that's
it's
where
funny because
the
I
problem-
always refer to us as a dysfunctional family because we do everything together. We go on vacations together. I mean, my grandchildren, my darling bride sees them 6 days a week. I only get to see them 4 days a week.
Yeah.
But if there's anything that I can complain about is ungrateful offspring number one is always worried about me. It's like that monitor for diabetes. If it goes off, you hear the beep, 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 and then the phone rings. And it's Lexi saying, "Did we have a cookie?" So you can't put enough value.
Yeah, I bet you're secretly really appreciative of that, though.
As I say, you can't put enough value on the fact that they care enough
Yeah,
because she monitors my glucose more than I do.
yeah. There's some
That's
patients that
great.
don't have that.
Yeah.
That's
That's
sad when we
sad.
see that.
I
Yeah.
mean, we grew up with my mother living with us. So we never knew what a babysitter was. And then when she turned 80-some and dementia set in, all of a sudden we had to get grandma babysitters. And it was the first time ever that
Yeah.
we couldn't supply everything she
Right.
needed.
But you repay the favor, right? She helped you, you help her.
That's all
the
there
way it
was.
works. Yeah.
And my two daughters were more protective of my mother than I ever could be. Ed, we had a new ER, we've had new expansion. What's new and exciting coming up?
I think still to come. Mostly we're focused on aligning with UMass in terms of their infrastructure in the short run. So that's really important for the next year. At the same time, though, we've got a lot of different projects coming in. So Shields MRI is going to take over our MRI service. We're going to do a joint venture with them. So that's going to start in December. Behind the scenes, again, UMass is doing a lot of inventory in the community, at the hospital, looking at what's the next expansion. So again, we've talked about different things at the hospital: surgery, GI, maternity. We're waiting for UMass to kind of finish their work, but we feel from UMass that they're very interested in assessing and trying to keep more patients in the community. They're full in Worcester. I mean, that's the problem. Sometimes they get 80 admissions waiting for beds. They like the model that we have of keeping more stuff locally. So we don't have an answer yet, but it's being worked on.
The urgent care, Is that as profitable as the hospital?
It probably varies by the time of the year. It does vary, it does well.
Yeah, it's a it's a good business for us. So the short answer is yes. You know,
Well, that's
it's,
good to hear.
yeah, it's, you know, summer's slow. A lot of people go away for vacation. They go to urgent cares and where their summer homes are. Milford isn't it's a destination for summer vacationers, unfortunately. But, you know, I think our, our high COVID winters were booming years, winters, which was good financially. It was good that they were in urgent care and weren't sick enough to go to the hospital as well. You know, so it varies. So urgent care is very kind of acute illness dependent. But overall, they more than kind of cover their costs.
Well, that's good to hear because it's so convenient
Yep.
to have the urgent care
Absolutely.
facilities.
Yep.
You know, I don't know how many times I've walked out of Dr. Williman's office and I need to do lab work. Well, before I walk out the building, there's the door right there, I get it done. So my compliance is higher. I don't think it costs me any different. So I like the idea that it's there. I like the idea that the level of care is the same. You know, that you're getting the same people in the ER as in urgent care. I mean, the same doctors, the same level of medicine.
Yeah, and just to clarify that, the majority of our urgent care providers are NPs and PAs. We do have a physician working at one of our sites who's available for all our NPs and PAs, but I don't want people to be, you know, misinformed. But the majority of the staff, the providers that you would see at urgent care are NPs and PAs who are excellent and most have many
very
years'
good.
experience.
But
And-
if I go to my physician, I see NPs.
Yep, yep.
That's what I mean by the same
Yep,
level.
yep. And they're outstanding. We've gotten great feedback from patients. I would say we get more kind of positive remarks on social media or directly to us from about our urgent care providers than anyone else.
Final words?
Success through the first year of UMass, we're feeling the same for the second year. Again, we're here to take care of the community, and we appreciate the community's support. We've actually got our Melange event coming up November 1st. It's going to be at Gillette Stadium this year, so it's really exciting. And again, I just feel that we have we have an obligation to take care of our community, but our community really takes care of us, so that works.
Well,
So
it's
we're looking to
always-
keep it going.
Respect is earned. And I'd say the three of you and the staff have earned the town's respect. Well, I shouldn't say the town, the area's respect for the decisions you've made and the stewardship you've shown.
Yeah.
So thank you.
Well, emphasis on the staff at the hospital and MRPG.
Agree. Thanks, Al.
Thanks for joining.
Thank you.
And to our 6 loyal viewers, as always, may tomorrow be a better night than tonight. May God bless and be comforted that our medical needs are in good stead.